thing and okay, fine. Can I
If
have a
you're
visual? Can I have a confirmation whether it is visible?
Yes, yes, it is visible, and if we could see your video also, it would be very nice. Anyway, you can
No,
take
no,
that
I
decision.
think video is on, I guess.
Hmm. नहीं,
Uh,
yeah, yeah, your slides are visible.
on the video, I didn't turn it off. I think it's fine, I guess. Yeah, it's on. From my side, it is on.
Okay, 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 all right.
It's fine.
I think
Yes, visible.
his
It is visible, Narendra.
Okay, okay,
okay, okay, all right, all right.
Yeah,
okay.
yeah,
Thank
it is
you.
visible.
Okay, fine. So before to start the sessions, what I'll do, well, let's start with a kind of a mini game, short game. It's a fun exercise. So in this exercise, what I'll do, I'll give you two scenarios, everyone, two scenarios. And what you have to do is that you have to choose, you have to tell me, you have to inform me that out of these two scenarios, which one scenario you will register in your memory for a longer period of a time. Am I clear? Let me be clear once again. I'll give you two scenarios. I'll describe two scenarios, and you have to tell me out of these two scenarios, which one scenario you would be registering in your memory for a longer period of a time. So now I'll describe to the two scenario. The first scenario, imagine that we all are hostelers and we are devoid of great food. So what happened one day, fine day, is that we are being invited by our friend for a marriage party. So, and we had a lot of expectation in that today we'll have a fabulous food over there. And as per expectation, we got our food. When we went to the marriage party, we had a pleasant food and we're satisfied and we came back. That's the first scenario. The second scenario, same one day. Again, we're invited for another marriage party in a different day. And we had a lot of expectations regarding that. Today will be a fabulous day ahead. But when we reached to the marriage party and the kind of food that we ate, that was not to our expectation. That was very unpleasing. That is very odorless. That is tasteless. That is unappetizing, very much unappetizing in nature. And we are not at all satisfied with that. And it was a horrible experience. It was a horrible, horrible experience. So now my question is to all of you, which part of this, which part of these two scenarios, or which of out of this which two scenario you would be registering more in your mind for a longer period of a time? Please do respond. I don't know why this is moving. Please, anyone? Is there any chat box here?
Yes, the chat box is here, but in between your voice was breaking. Whether that is the problem from my network, or I think it is for the all the people. People could not hear few of the thing in between. Other people will help me whether it is the problem from my side or from his side.
Is my voice properly audible? Can I have a
Yeah,
Now,
it's audible. Yeah,
yes, yes,
audible,
audible.
Narendra.
Yes, yeah.
Okay, fine. Chalo. So please, can anyone have a answer to that? Which part of this two scenarios you will be registering more in a memory out of this two? Which two scenario can we have? And some people are waiting in the lobby. This message is constantly showing. But anyways, I'll take for granted. You are responding to some this question. So I don't know what is happening. Okay. So let hold this information back in your mind and we'll come to this answer later on. But answer to that question is very crucial to part of my presentation. Let be clear with these two questions and we'll come later on. Fine. So today I'll be given a task that I'll be talking about recent advances in exposure therapy. Basically here I will be talking about the application of inhibitory learning principles. And in the terms of exposure, and if the time permits, I'll be also talking about how we can maximize the non-specific factor within the exposure sessions. I don't know what is happening. Okay. We're talking about how to implement the non-specific factor in our exposure therapy. So basically about these two techniques I'll be addressing, but I'll be mostly emphasizing the inhibitory learning concepts. So let's begin with that. But before that, let's do kind of a recapitulation, because I was being informed we have a mixed crowd in terms of we have professional as well as students. So I'll try to do justify and try to do kind of justice to both of these things. So sometimes would be easy and sometimes it might be technical. Anyways, so just have a recapitulation what I think we all know. We are here mostly students of clinical psychology. So before start of any therapy, basically we'll be taking systematic information in overall basis on three major related areas. First would be fear cues. And basically I'll be telling you the applications in the terms of anxiety disorders, exposure therapies. So when you're taking this information, the first information that we'll be taking more in terms of is the fear cues. What the individual is afraid of. What are the specific stimulus? What are the specific thoughts? What are the specific objects? What are the specific events? What are the specific images? What are the specific impulses that individual is afraid of? Yes, simple kind of interviewing questioning that can also help, but we recommend to obviously go for a recommended skills to augment our interviewing skills. And say for example, there are a lot of accepted and gold standard criteria of skills that do assess of a range of fear cues of across various anxiety disorders. For example, for panic disorder as well as agoraphobia, we can do mobility inventory. For social anxiety scale, we can go for Levoy social anxiety scale, which to have a 24 social situations measurement in that. For a specific phobias, we can go for claustrophobic situation questionnaire. For OCD, apart from white box, we can also go for some compulsive activity checklist. These are the few recommended skills that the main purpose of using the skills that the situations are given in a more. So if we'll be implementing, we can cater some of the questions that we are not, perhaps we may not ask. So next, I'm not able to move the slide. It was hello. It's fine. Sorry, it's fine. So after the taking of the fear cues and events, basically we'll take about informations related to the fear consequences. Say for example, 5-6 fear cues you have taken from an individual. Those are the fear cues in relation to each and every fear cue. What are the fear consequences? What exactly the individual is thinking about of that particular fear? What is anticipating that something negative might happen? What exactly are the fear consequences? That, and third is related to the coping mechanism used by the client. So before therapy starts, what sort of coping mechanism they have used when they face those kind of feared cues and feared events in their life? What are those kind of safety behavior? What are those kind of compulsive or neutralizing behavior? What are the forms of avoidance? How the avoidance was being used, or any other kind of coping mechanism used by the client? So we have to take a systemic information about on these three related areas. So this is basic recapitulation. I think everyone knows about it, but just we did like for that. So let's start with the first step of conceptualization. You know, in conceptualization, basically it does have two key components. First component is understanding the maintaining factor of a problem of that particular individual. And this understanding actually already has started when we did the assessment on the last slide. We discussed about the three steps. This conceptualization already has started. We first need to understand the scientific rationale, or you can say the maintaining factors as per the cognitive behavioral paradigm. What are different kinds of maladaptive thoughts, and what are the different kind of maladaptive coping mechanisms or behaviors, and what is and how the interplay of that exaggerates the symptoms. So you need to have a kind of obviously a paradigm as per the CBT paradigm. You need to understand the rationale behind it. That is the first part of the conceptualization. But the most important part in terms of progress of therapy is the second part of the conceptualization, that is communicating our understanding back to the patient in such a manner that the patient understands also in the same line that these are my maintaining factors of my the problem, if and these are my roadblocks to recovery, and if I'm going to take care of those things, then I may come out of the flying colors. In a way, he also need to have a thorough understanding, not thorough, I'll say, a basic understanding of the scientific rationale that you are going to work on. And the way, the more thorough and the more convinced is about the conceptualization, the more convinced about the rationale of the treatment, it leads to better credibility towards him, towards the our therapeutic program. You'll have more credibility. You'll take the therapy that is up to be more credible in nature. Obviously, that might lead to the more expectancy of a development of his own symptoms. That that also related to his, well, what might be the favorable outcome. Maybe due to this, treatment process, I would be also getting a lot of treatment benefits, and I expect myself to change a lot during this treatment process. That expectancy, and if this credibility and expectancy is there, it might also lead to a better adherence, and adherence in terms of that better follow, they will follow the kind of various regimens that we'll be telling him to do in the future. The basically exposure, obviously we all know that that might be a challenging in a sense, if no matter how convincing way we do our therapeutic procedure, but if there is not an adherence, success may not be there. And this all the foundation of lies in how we are able to give conceptualization to the patient. There are many ways, there can be many ways of this providing a conceptualization, but all of the ways at least share one common thing. The, the way we need to communicate the conceptualization has to be very lucid, very easy, very layman terms, so that, and even without using of lot of technical jargon, it has to be communicated so that the patient understand at his own level. Yes, so today I'll be narrating one of the techniques that how we give conceptualization in our scenario. And basically the conceptualization that we used to give with the help of a metaphor, and that providing that metaphor, the main aim in our head was to provide the conceptualization in a reflective manner. We'll be putting the situation, the patient in a specific manner, then we'll be asking questions from the patient. Yes, we really acknowledges that the way we do give a conceptualization that may have many lacunas, the metaphor may have many lacunas, but the reason is very simple, to invite a reflections from the patient, rather we telling him everything that he should give him certain answers. And those metaphors are very easy in manner, it's very layman way manner. So I'll narrate that, kind of how we give a conceptualization. That's very simple, and bear me with that simplicity. This is the way we convey to our patient. So I'll start with that metaphor, how we communicate our conceptualization. So what I'll say to my, this is the way now I'll be telling, this is the way I tell to my patients. We tell to our patients. Imagine that you, you are all sitting, yeah, you are all patient. Imagine that. So I'm telling it to you like that. Imagine that I tell to my patient in this way, imagine that I am your younger brother and you are my elder brother or sister. And the room that you all are sitting, imagine that is again our living room. So we are sitting there, and one fine day, what happened? When I was going to corner of the room, suddenly I have a terrible itching all over my body. A terrible itching. It was that terrible for that I went for a physician, applied medication, then the itching has something little bit subsided. So from that day onwards, I developed a pairing in my mind. If I go to the corner, itching will definitely happen. That was kind of a pairing, it was developed in my mind. So with that fear, it was there established. So next day, what happened? When I was going towards the corner, what happened is that suddenly there was a lot of terrible anxiety. All of bodily sensation give a sympathetic, it was very much high, and lot of anxious feeling I was feeling that. So it was really a terrible feeling, and nobody likes that feeling. So what I did an avoidance. Before going to the situation, there is a rise in the bodily sensation, was very uncomfortable. But when I did the avoidance, I decided I won't go to the corner. The moment I decided, those things properly reduced. So that was a pleasure for me. Actually, that was a reward for me. So, well, after the avoidance, there is a reduction of anxiety. So every day I kept on avoiding, but everyday avoidance is not possible. Every situation avoidance is not possible. That is my own room. That is my own corner. Someday I had to go for a different reasons. So one fine day, what happened? Something was there in that corner that is very much required. Maybe a dress is hanging there. Maybe something else that is very much required. What I did is that before even thinking of going there, the bodily sensation was taking place. Well, then what I told to my elder brother, who is the patient in this example, could you bring that the thing for me? Then he brought the things towards me. But after getting the things, again my anxiety, my distress level decreased. So this kept on happening. Either I was avoiding or taking help from any siblings or any parent, any individual in the family member present over there. One fine day, what happened? None of my family members were there, but still I was requiring something from the corner. So in that scenario, what I did, I got a stick, and from a distance, I tried to pull the things towards me without going to the corner. After getting the things really subsided. Things there's a decrease of the distress level. So by putting this kind of scenario, I asked to the patient what benefit he was getting. The most benefit is that there is an immediate reduction of anxiety. Then my questioning starts from the patient. I don't give a lot of answers there. The questioning is the key. Then I asked to them, by using these three things, yes, there was an advantage, there is a reduction of anxiety, but now you tell me, it all started with that pairing. If I go to the corner, itching will happen. Whether that pairing got reduced after doing these three things, then almost everyone patient say no, it doesn't reduce it. Maybe it was there, or it maybe become stronger. It never reduced. But yes, what they say, we try to bring a discussion that yeah, is a kind of a dealing the situation, but the thing was already there. Then I tell him, then what you would advise. Say for example, you want your younger brother to to overcome this fear towards a corner. What you are going to advise him? It's a very simple question. So basically, they give an answer that yes, in a way, he has to go to the corner. Unless he goes to the corner, there might be not any substantial improvement. First, I may accompany him, but later on he should alone go to the corner. Unless he is going towards the corner, how much be their improvement? To hear this answer, to this hear this particular kind of answer, the whole this metaphor was communicated. So through this example, what I established, yes, these are the kind of unsafety behaviors, and what is the role of safety behavior, and what is the role of the exposure, and how the safety behavior, how the faulty coping mechanisms actually increases this pairing that is already established in the mind, the negative misinterpretation in the mind. But if one need to overcome that fear, one has to do exposure. And this I didn't tell him. This is what the patient, I wanted to hear it from them. But again, I asked two questions to them. What I told that for 6 months, the individual did not go to the corner, but you told him that he has to go. But when he's going towards the corner after 6 months of avoiding and all doing these things, whether when you'll go for the first time, whether would not be there any kind of fear? Yes, definitely there would be a fear. He told the patients used to mostly they used to be telling, yeah, there would be fear. But the important thing here is to know. We'll try to bring a discussion whether itching is happening or not. Fear would be there, but he has to know whether itching is happening over there. With that example, I give him trying to say maybe in the first day you face something, might be a terrible anxiety. Second day you went again, you didn't find any kind of itching, but might be a lesser anxiety. So subsequently 5-6 times you go and you establish there is no relationship of the corner and itching, then he might overcome from that fear. But for that he has to go. Now come to the second question. I asked him, okay, after the 7 days, as you told, your younger brother has to go towards the corner. But after the 7 days, 6 days, he did not have any itching. One day he had an itching. What he should believe more, 6-day experience or 1-day experience? Indian MSL, everyone must will say, no, it's a 6-day experience. One day it might be many kind of, ittefaq, it's maybe coincidence. maybe he had certain kind of allergy, maybe that got manifested there, or we then we bring into a discussion, maybe something there in the corners, that was an old room, maybe something really fall from to his shirt and he got an itching. So anything can happen, but if things are happening persistently, one should believe that. Once in a while, that may be coincident, that may be a thing, but whether that is happening persistently, that he should believe it more. So through this example, what I try to do, then I come back to the clinical translation. The things that I have collected the information in my assessment, I come back to the clinical translation to this. So here the feared events may be, the patient may have, if I panic, I might die. If there is a social situation, that if I go to the social situation, I might be, say, I definitely will be scolded by others. If I'm going to touch this mug, definitely I'm going to have a disease. If I'm going to wear this kind of dirty dress, then definitely I'm going to have a disease. If I'm going to think about something violent, definitely I'll do that impulsive action. I'll do as per my thinking. So the feared event, fear consequences. So then in order to, and that led to a significant distress level. So in order to cope that, people do a lot of safety behavior, avoidance, neutralizing behavior, and other kind of safety behaviors that gives an immediate reduction of anxiety. And how persistent use of those things are actually increasing or manifesting or strengthening the symptoms, we try to explain in that perspective, and how exposure is the adaptive solution without using the safety behavior. This is how we communicate the our problem to this is way of conceptualization. It's basically the main aim was to provide a reflective conceptualization. We put him in a scenario, we ask him, and the person has to tell certain answers. So this is a one way. And basically if we go in classical emotional processing theory based exposure, we'll be talking about ILT, but a minute or two about EPT models, emotional processing theories model. What they do focus on that, yes, when you have collected the feared cues, you make a hierarchy of that, maybe 5 6. So you need to start from the middle item, that is what uh, and from that progressively we have to increase from the middle item to the top item. And every session will be following a subjective unit of distress, and it has to be until unless one get a significant within session habituation or reduction of anxiety, and that within session habituation lead to the between session reduction of anxiety, then we won't move to the higher level. This is what is the basically emotional processing model that FOA and Kozak really popularized. This is an old model of not I'll say old model, but yeah, this model was very popular, and still it has been used in a lot of numbers. And obviously that's a stand, maybe uni-choice and numero choice in terms of exposure therapy. But here the question lies that when we use TPT models, there has been seen that even up to 30% of the patients do are non-responders. In a study, in a lot of studies, is kind of an average. So 20 to 30% are actually non-responders from the CPD models. And out of and those who have responded positively post exposure therapy sessions, 50 to 60% do have a relapse or return of fear in latter point of the time. So it really became like that, what could be done, something extra, that so that people will have a more responders to the exposure therapy, and how this return of fear can be tackled, how this relapses even among those responders can be tackled. So many researchers went different strategies to develop the exposures or different techniques to overcome these pitfalls within the emotional processing models of therapies. So in 2008 onwards, yes, this Krashke come with the innovative learning concepts. Not innovative learning concept, it started many years back, but she applied those concepts in terms of exposure, how the exposure techniques can be developed so that it can it can meet the criticism associated with the earlier models. So we'll go about that. What is innovative learning model? We'll try to understand that, and what techniques we use of innovative learning model in terms of exposure activities. We'll explain to that. So let's first start with that. With this kind of a conceptualization of ILT concept, When the patient comes to a therapy sessions, he comes with a threat expectancy. This conditioned stimulus will lead to unconditioned stimulus. Say for this unworth stress is going to cause me disease. If I'm going to panic, I'm going to die. If I'm going to a social situation, I might be rejected. So this kind of, they do come with a threat expectancy. It is there in their properly in their memory. And during our extension learning, during the exposure, what we try to create is a non-threat expectancy. Yes, if you panic, you may not die. If you wear this dress, you may not have a disease. If you think will that particular dangerous thought, you may not commit that thought in actual. So we try to teach them non-threat expectancy. We try to develop this non-threat expectancy. So what happens is that these two kind of memory, one is threat expectancy, other is non-threat expectancy. Again, I repeat, this threat expectancy and non-threat expectancy, these two different memories are stored in the memory. These two memories lies, this non-threat expectancy is one additional memory we are giving, we're trying to make him learn. So this is a new meaning, and this both meaning stays in one's memory. The second part of this model is that what in earlier models, previous model, emotional processing theory models, we are thinking that by actually our this extension learning, by our exposure activities, we are actually erasing this threat expectancy. We're trying to removing this expectancy, but in truth, in reality, both of these memories lies there. Both of this meaning are stored in the memory. It might be that this threat expectancy might be less available when the memory related to non-threat expectancy is more dominant in one memory. But yes, nothing get really erased, it lies in the memory. This two kind of memory related to the same condition stimulus lies it. But how that is being determined, which will be dominant, which will be non-dominant memory, how that will be activated, let's try to understand in a clinical application, then we'll have a more clarity to it. Say for before exposure therapy, let's try to understand the clinical translation. Before exposure therapy, the individual comes with a threat expectancy. If I'm panic, then I'm going to die. If I'm holding knife, definitely I'll commit some kind of bad act to my family members or do some kind of harm impulses. If I'm going to social situation, I might be rejected. They are coming with a threat expectancy. In the exposure therapy sessions, we are teaching them non-threat expectancy. We are trying to conduct exposure to prove that yes, it might be a non-threat expectancy. Here, this threat expectancy in this ILT concept, we say excitatory meaning. Yeah, something bad is going to happen. And this non-threat expectancy we have turned as inhibitory meaning. That threat may not happen. Not this non-threat, this stimulus is not predictor of something negative. So this is inhibitory in that way. This is the inhibitory meaning. So what is going to happen in the post-exposure session? There will be two things. Either there will be fear or no fear. There will be fear or no fear, depending on which part of the memory is more activated. Say, for example, if this threat expectancy related memory is more activated in the post-exposure session, there would be fear. If there is non-threat expectancy related memory is more activated in the post-exposure session, there will be no fear. But how these things are dependent means which memory will be more activated means how this is really being determined. That is a $1 million question. Say for what happens now, try to understand this exposure related memory or this exposure related non-threat expectancy or this inhibitory learning related to non-threat expectancy are highly context specific. Just a minute. Okay, these are highly context specific in nature. Say for example, if an individual has learned a non-threat expectancy related memory in one particular context, and in the post-exposure session, the context is completely different where he has not practiced. So there, the high chances is that the the threat expectancy would be more activated. For example, if a client has learned something in the particular context, if in the contamination related fear, the patient has practiced more in terms of his home, in terms of therapist office, but he moves to a different city. He went to a shopping mall at a different city. So there it's a different kind of an little different kind of an context. So there, the more chances is that the memory related to threat expectancy would be more activated. Hence, you have a fear. Hence, this memories of non-threat expectancy are highly context specific in nature. If context changes, things might change. Second is time factor. For example, an individual having a claustrophobia who was given kind of a treatment related to exposure in terms of in a lift or elevator. He was given a proper exposure exercises, but after the therapy sessions, he somehow went to his village and he never went to any kind of lift, he never went to kind of any elevator for maybe 5-6 months, for example. But after this 5-6 months, again is exposed to those elevator, he might have more fears related to the threat expectancy. That is known as return of fear or spontaneous recovery, because he has not practiced for a significant period of a time. So there might be a return of fear, there might be a spontaneous recovery. Third component is a reinstatement of fear. Say, for example, in the social situation, we are giving him exposure activities, but when he goes back to the real life during the post-exposure scenario, what actually happened? Somebody really in the social situation, shouted on the individual. He was actually being criticized for some reason in one specific day. So that is reinstatement of fear. Something the individual is fearing that really happened. In that scenario, the memory related to the threat expectancy would be more activated. Hence, in summary, this non-threat expectancy related memory are highly context specific, are highly time related factor, and they do have paralyzed by the reinstatement of fear. In comparison to threat expectancy memory, they are not context specific. They are highly generalized. They are highly, if fear is there one place, it will generalize to many other places. So what the design is that the main purpose of here this innovative learning theory model is that how to make this non-threat expectancy immune to this context renewal effects, immune to this spontaneous recovery, and immune to this reinstatement of fear. If not immune, how our exposure therapy can tackle these three problems which might happen in the real life scenario. In a way, to more simplify it, how this non-threat expectancy will have more storage capacity in the memory. It will have a more retrieval queues so that it can really upset the challenges done by the threat expectancy. It will upset the context renewal effects, it will offset the time related or spontaneous recovery, or it will also handle the reinstatement of fear. To say once again, the goal of non-threat expectancy the goal of this innovative learning model is to make this memory as associated with non-threat expectancy to immune to, if not immune to, deal with context effects, to deal with spontaneous recovery, to deal with reinstatement of fear so that it can compete the threat expectancy related effects. And how to do that? So I will tell about the various techniques to that. So basically those techniques, when I'm going to say that, those are very little modification. If you compare those techniques with the EPT model, it may not be the huge differences, but the ideology which they are using it and certain minor differences really plays a huge role in this ILT model. So now I'll come back to the question, the kind of scenario that I asked you in the very initial part of my presentation, that which of those two memories or two scenarios you will register more in your memory for a longer period of a time. And obviously the scientifically the answer would be where you had a mismatch of expectancy, where you expected that you will get a fabulous food, but what you got is real something very different from your expectation. More there is a mismatch what you're expecting and what the outcome that is happening, that is higher chances of getting stored in the memory. So that's technique. They have adopted it as an expectancy violation technique. So now they will be designing the exposure therapy in such a way that it will provide a maximum chances of such expectancy violation within the therapeutic process. They have to create expectancy and they have to violate the expectancy. So this has to happen. More the mismatch of expectancy and the outcomes does happen, greater is the inhibitory learning, greater is the non-threat expectancy related memory, greater is the storage capacity of non-threat related memory. So when I'm going to explain about this, uh, expectancy violation technique, it will also be very similar to kind of belief disconfirmation model of ARP. So the questions might be arising how that is different from belief disconfirmation. Yes, it is different from habituation model, but how that is different from belief disconfirmation model. Yes, it overlaps in the belief disconfirmation model in some stance, but the basic difference it with the belief disconfirmation model is that here they highlight maximum opportunities to create such mismatch of expectancy. They want these people, they want us to do to challenge or to create the exposure in a number of different pattern, so that more opportunities would be there of certain expectancy violation, which was not previously so much there in the belief disconfirmation model. So let me walk you through the few examples and few techniques of how to increase this mismatch of expectancy and how what kind of opportunities we can create in our exposure to have this mismatch of expectancy. Let me walk you through a few of these instances. The first would be temporal prediction related. Say for example, you might ask to the clients, what length of time, if you're going to hold knife, do you expect to harm others? Okay, if you're going to 5 minutes, are you going to really harm others, or 6 minutes to 7 minutes? How much? Initially, it was not touching now. Yeah, but if you're going to hold the knives, how, in what length of time you're really going to expect harm others? Maybe 5 minutes, maybe 7 minutes. Okay, let's hold this knife for 5-7 minutes. Let's see what happens. This is a temporal prediction. When after that 5 to 7 minutes, if that is passed through, okay, let's then how much really now you expect? In this 5-7 minutes, you did nothing. So how much you really expect now? Then patient might say 10-15 minutes more. Well, make him hold the knife and let's wait for 10-15 minutes. So this expectancies may shift between various sessions. Sorry, it may shift within a sessions in a various ways. This is also temporal prediction. One other example, say for what length of time, if you're holding this dirty mug or dirty brush without washing it properly, do you expect to have a skin disease? Maybe 5 minutes. Okay, let's hold for the 5 minutes. Let's see what happens. This is a temporal prediction. Second is intensity of expected unconditioned stimulus. The question will be how intense will be the disease. Say for example, you told in the previous stanza within 5 minutes you might have, or 10 minutes you might have a certain stomach infection or skin disease, or you might if you are going to die. So yes, can you show me the intensity of it? How crude will be the skin disease? How, what might exactly happen to your skin? Can you give a little bit kind of verbal description or what you expect? Little bit. Let's see how intensity it is going to happen. Third is related to the frequency or occurrence. Uh, for example, what is the likelihood of disease every time you are exposed to public toilet? Say for example, is it like that for 7 days you'll be going to public toilet, 7 days you'll have a different diseases, or maybe even the same diseases, or every time we go to that particular washroom, use that toilet room without washing it properly, you'll have a certain specific disease. If you're touching that, you'll have a specific disease. Or 5-6 days every day, if you're staying alone in the lift or in the claustrophobic room, you're going to die. Is it once day or frequency? Every time when you go there, you will be a certain consequences. Let's even put into the exposure exercises. And one of the most commonly and least used but highly beneficial is the capacity to tolerate expectancies. Sometimes patients say, I cannot tolerate even standing there for 5 minutes. Okay, you are thinking you are not able to tolerate it. So if you're going to stand there, what might happen? Means what is will be a tolerance level? Will you be faint? Will you be what? Just tell me what things can happen. Okay, let's stand for 5 minutes and let's see what really happens. So after 5 minutes, when he stands some to the phobic stimulus, and we might ask them whether that is really intolerable, or whether that is more than you expected or something lesser than expected. Somehow patient might say it's maybe more than expected, maybe lesser than expected. Okay, how much time you more can stand? Maybe 10 minutes. Yeah, I stood it for 5 minutes. I think I can stand more, about 7-8 minutes. I cannot stand more than that. Okay, let's see whether you're able to stand or not. So we are also here challenging the capacity to tolerate, expectancies. But thing here, one crucial thing is here is that all of these things cannot be practiced for every patient. This you have to have a clinical acumen. Out of these four things, what really can be targeted? In every scenario, temporal prediction could not be targeted. So you need to, this is a kind of a way that as much as possible, how much this expectancy violation things we can do really integrate in our therapy. But yes, for every patient at every session, this may not be done. Some of these techniques may be applicable, some may not be applicable. It depends on your clinical acumen. And this way, as the more there is a mismatch of expectancy, it is understood that learning will be better consolidated, and it increases the storage strength of the innovative learning related memory. For this, a format can be used to make it more clarify. What we really advise is that make a proper form like that, what your in one column, what is your expectancies, what activity you did. So after doing that activity, what really happened in this three way. First, what is your expectancies if you do certain activity, then what activity you did in the second column. So after in the third column, what really happened in terms of expectancies. If it could be written, that will be also more better way, will be a more objective kind of report. Let's come to the another technique of deepened extension. And personally, this is one of my favorite technique, perhaps the favorite techniques within this ILT concept. What happens in this deepened extension is that uh, when I told emotional processing model of therapy, what we used to do, we used to expose the individual to one cue at a together, means at a time. In deepened extension, what happens is that here we would be combining two feared cues together, provided those two cues has, the individual has faced individual exposure on those two cues previously. If the individual has faced those kind of cues previously, then in the next session, we can combine these two feared cues together and expose to the individual at a particular time. This is the combination, deepened extension. I'll give you a certain example that will be more clear. But the thing is that whatever cues you're combining, maybe dirty mug, or maybe some other utensils that the patient, or maybe a non-veg object the patient was not even touching, it can be clubbed together. And all has to be predict the same kind of fear. Maybe you can combine the things that is predicting pathological doubt. You can combine the things that is predicting the contamination related fear. You can combine the things that is predicting the symmetrical related fear. You can combine this thing that is related to the bodily sensation fear. But it has to predict the same thing. That is the main basic logic behind that. Yes, let's come to the example that will be more clear of this dependent extension. Say for example, the two cues they were combining, it may be one internal cue, another external cue. This are very much used in terms of claustrophobia and agoraphobia patients, panic disorder patients. These three categories use it a lot and lot and lot. Say for in the first sessions, we did individual interoceptive exposures, that is internal bodily sensations, we did exposure. Then after the patient has got a little bit convincing responses on this internal exposure, and we take him in the older model, we take him into the external. Say for we make him go, say for example, go to a far distance place alone, and that is kind of an exposure. But here what we can do after these two things has been done individually in the deepened extension, what we can say to the patient is that go 5 kilometers away from your home, that you are not even going even 1 kilometer, you are now going to 5 kilometers away from your home. Then after 5 kilometers, be alone there and do the hyperventilation exercises. do the interoceptive exposure there, being alone, away from the home. So you can combine both internal and external together. Then do both examples of internal. Say for example, it could be OCD related thoughts. You are putting exposure to two kinds of different uh, types of thoughts. Say for example, one thought would be harming about others, exposure to that, having intentionally thoughts about harming others, and one exposure related to blasphemous images that the individual is not comfortable with, intentionally thinking about blasphemous images. So it's two thoughts together can be thought about simultaneously. Exposure can be done. And external also, it's very easy to demonstrate. Say for example, in terms of OCD, you are giving him a dirty mug and you are giving a knife, you're holding him, hold the knife together. So this will be not proper example. Yeah, two something contaminated kind of objects can be given together and will be can be asked his expectancies. What is the rationale behind it? Why this dependent extension is done? The thing is that it increases, as per the conceptualization of ILT, it increases the mismatch of expectancy. Obviously, when there is one object, now we're combining two objects, there would be more expecting something really bad is going to happen. But yes, what outcome is going to happen? So increasing more cues in one session, it might create more mismatch of expectancy. It gives an opportunities to create that more mismatch of expectancy. Second, is very important for this reason, is reduces reinstatement of fear. As we discussed, basically the old models of exposure are being affected for these three reasons. First, there is a return of fear, there is a context renewal effects, third is related to the reinstatement of fear. So when in the dependent extension, say for example, when the individual is given exposure to one stimulus, after 10-15 minutes, we are adding another stimulus without even asking him. Though he might have practiced it beforehand, we are reintroducing the another stimulus together. So that is something, is a suddenness that is coming to patient's mind. That suddenness of fear we're trying to increase in between our sessions. So that is a reinstatement of fear. It is a good practice to overcome the reinstatement fear in the relapse prevention stages. That really helps, and a lot of papers are coming particularly using this particular technique. So these are the advantages of deepened extension. Now let's come to the third technique of inhibitory learning, that is variability in the context. Again, I'll be going back again and again to those kind of three drawbacks that is associated with the emotional processing model. One of them that is that inhibitory learning models or inhibitory memories, not models, I say non-threat expectancy related memory, are very context specific. If the individual faces those kind of fear in another context, there might be more memory related to the fear expectancy, threat expectancy. Hence, in the variability of in the context, and this is somehow you all might have been doing it, but what this ILT model has done is that it has brought more structure to our homework sessions and our exposure sessions. Say for example, um, I'll give one example first, then I'll come to it, the benefits later on. The example would be, basically we do expose it at the clinic and home. In the patient's home, he used to do the homework exercises. In the hospital, we do exposes before them. So we can also tell him that, like that, do this kind of, say for about this contamination related fear, go to the nearby restaurants, go to my nearby shopping malls, do also practice, do that. Various homework sessions can be given into for different context. Same kind of unconditioned stimulus, but in a different context, so that there will be a lot of generalization. This is the most important word when you're talking about variability in the context. We want to generalize the findings of inhibitory learning, non-threat expectancy, attached to a lot of different contexts, not only to the context of clinic and home, but as much as possible in a practical standards. Another example, thinking of a blasphemous images. Say for example, when the patient do complain that when he is sitting in maybe at the temple's room, at the prayers room, he's having this kind of images. So not only exposure at those home temples, it may be outside temples, it may be the cremation ground, it may be other related areas, other different places. We asked him to go to various contexts and do those things in a those kind of exposure in a natural manner. What interestingly even we did with our patient is that use of surprise card. What is the surprise card in terms of that? In homework sessions, we used to do that. We'll be writing something to the patient. We ask them, you say we have given a homework session for 3 weeks, 2 weeks, say for example. So this 7 days, you do this kind of exposure activities, and in the second week, try not to open the chit in the first week. Do open in the second week what exposure activity is written in different contexts. You have to do it. We do we advise that do not see those. Try not to see what is written in what context it has to be done in the first week. When this is in the second week, you see the this is my activity need to be done. Let be a surprise for you and do that exposure activity. That is a different context based. Maybe he was doing for 7 days in a different context. Then 8th, 9th day he'll be doing another context. Then 11th, 12th when he'll be doing another context. Obviously, what context we are giving to him, that is depends upon the case history, how practical that would be for the patients to appear. This all these things has to be taken into consideration. Why this purpose of a surprise card? Again, the surprise card we are actually practicing him for learning the concept of reinstatement of fear. Something happens suddenly. If something suddenly it is happening, how the patient is reacting to it. Even that suddenness of exposure, even it has to be practiced during the therapy sessions. That is one beauty of the variability in the context. Yes, the benefits are the more, as I told, it increases the generalizability. It increases storage capacity of inhibitory learning in our memory, in our brain. For it attaches a lot of retrieval cues with different memories. It is not tied to the context of home or therapist office or hospitals. Let's come to another example of, again, say variability. This I explained in the context. Now the variability in the order of cues, or you can say variability in the hierarchy that we're giving to the patients. Let's explain what basically happens in the emotional processing model that we just went to a bird's eye view. What we do is that we follow a particular hierarchy. Say for 5-6 things are there, the patient has to move from moderate to in a graded manner to the high. He cannot jump, or he cannot he may not what jumble of the order. He is supposed to go in a graded manner. But here, what does an ILT model does is that they advise to start with the list, not even the medium. Basically, we start with the medium hierarchy in the EPT model, but in the ILT model, they start with the list in the hierarchy just to avoid the treatment refusal. To avoid the just to have a buy-in approach. Start with the list activity, then do follow a random order. Not necessarily in that proper hierarchy. Those hierarchy that has been done, it can be done in a random way, not necessarily in the graded way the patient has to go. What is the purpose of it? What is the logic behind it? See, basically in the real life situation do not naturally occur in a hierarchical manner in the real life. In the real world, things may happen at any certain point of time, anything. Nothing really happens much, and this in the world will not think this is a patient, will give things in a hierarchical way. That suddenness might be there. Hence, if you are practicing that even during the therapeutic concept, it does have more external validity to the real life situation. It does have more external validity. If you're not following a random, if you're following a random order, this is one of the fiercest logic behind the variability in the order of cues. What is the second logic? The second logic is that when there is kind of, the more patient is doing this, the more the patient is doing this randomness, that speaking something in the random and doing the activity, there would be variety level of emotion. There will be a variable level of fear within the patients before doing the exposure. There is much jumbled up, and that really serves as a retrieval cue. Because what happens in the relapse prevention, if you see, if there is a certain other problems in the patient's life, maybe other kind of emotional issues, and those kind of issues, the maybe the neurotic tendency, maybe the anxiety tendency, maybe the OC tendency, we will re-emerge in a more fiercer manner. So in beforehand, we are making him practice in a variety of emotional states how he is also having non-threat expectancy. It's a kind of a practice to those kind of suddenness in the life. Hence, but problem with is that the patient may not get a proper habituation on the reduction of anxiety within one sessions, but in the long term it does have benefits. But here have a something to really discuss related to our experience. Very frankly, variability, when we discuss in the terms of context, we are very comfortable. But when you are doing this variability in the order of cues, in the order of hierarchy, actually we're really afraid as a therapist. So we take in a kind of an calculated most of the scenario when the patients are comfortable. Say for we ask them to pick things at random, but we take their opinion. Are you able to comfortable? Are you able to do this? Then do it. So this is kind of a little bit might be a personal fear related to it, because this is very in a very nascent stage of this variability in the order of cues. But this is a way many patients do really, basically in terms of claustrophobia and agoraphobia, what I have seen. And even in the pathological doubt in OCD, they do really agree to do this variability. So there is no fixed study about it in this, which patient will do more variability in the accept or not. But this is something related to our experience we're sharing. But certain people really, they really avoid, they don't, they're not interested to do this kind of randomness. When it is not interested, we don't force them. But this is one of the things there in the book that we told you about it. But yeah, many patients do agree this doing this variability. Another is concept is related to the reminder cues. See, there is, this most of the patient do a statement in the life to us, sir, I know what we need to do in that particular situation. We have learned, we will learn that we have to do exposure. We don't have to do any kind of safety behavior. There has to be response prevention. But at the hit of the movement, we give into our compulsion. We give into our safety behavior. We knew what we have to do, but at very moment we actually forgot what need to be done. What we have learned, actually we forget. But hence we kind of glue to our old habits of safety behavior and neutralizing behavior. And this kind of a statement might be a very predicament about all of us. Most of the important situations we really forget what need to be done and we go to our old bad habits. So similarly is kind of for the patient, for the same thing. They knew what to do, but sometimes at the heat of the moment they really do forget. Not forget, if I say simply they mess it up. Hence there is a concept of reminder cues. What is like is that the concept behind this ILT concept is that uh, what we advise to the patients that purchase something or take something something that you used to wear in a day-to-day life, and dedicate that this is a representative of something that you have learned. It's a representative of the non-threat expectancy. Say for yes, this I'm carrying this. Yes, the girl is wearing a different kind of chudi and one particular chudi of a different color. That the patient will indicate that, will dedicate as a memento that this is symbolizing that I have learned this non-threat expectancy related to XYZ thing. So this is kind of, if it is there in my hand, it is always available before my eyes. This is kind of a banger. Yes, obviously that would be secret. No, is not supposed to tell what that symbolizes. That is only for himself or herself. So that kind of reminder cues, it may be a chudi, it may be a wristband, it may be a note card, as simple as possible. Say for example, only a note instruction. If a person is not fashionable of wearing wristband chudi, obviously one example would be just simple, right? This is the non-experience that I have learned. Save it in a pocket or save it in a reminder as in the mobile also. This can be done also as a self-instruction. What really I have learned in a one line. This is a non-threat expectancy, but this reminder cues again not to be used in the early part of the therapy. It never has to be used in the early part of the therapy. These strategies are best employed as a relapse prevention skill only. Never has to be done in the initial stages. Why? The main reason is that it itself might have a safety behavior like a phenomenon. It may accrue the safety value. Secondly, the moment the person is having this kind of reminder cue, which is already is mostly visible to the patients, most of the time it is designed in that way. So that may, if in the it is done in the earlier part, it may reduce the mismatch of expectancies, the expectancy of the aversive outcome, it may reduce it. I do not want to reduce this at the initial part of it, our therapy. Hence it is not advised not to use this kind of a reminder cues, but maybe during at the end of therapy, maybe relapse prevention strategies when planning for these things can be added to the patients. And it does help. I have advised a lot of patients to at least do the studio wala example. It was fun. So yes, this is the kind of though. Can I have more 5 minutes? Actually, I'm over the time. So this is the ILT model that I described. So up to the organizers. Hello.
Uh,
It's fine. Otherwise,
yes,
it's okay.
please go ahead. Please go ahead.
It's for 5 minutes. That's it. This is I told basically two concepts we covered. I'll be covering first ILT concept. This is more or less I covered. Second technique is related to that. So broader themes. It's itself is one class maybe, but we'll just like a quick detour. One at least technique I will explain of that how to maximize a non-specific factor in our exposure activities. See, non-specific factor, it does means what we discussed in the ILT concept, that is something we say specific factor, specific models, in a sense that it is targeting something with the patients rectifying, say for example, identifiable deficits, maybe deficit in the cognition, deficit in the emotion, deficit in the memory. And while non-specific factor is also popularly known as common factor model, it means that those kind of factors which is present almost in every therapy, almost in all the bona fide treatment, it is present there. Those are common factor or non-specific factor. What are those kind of non-specific factors or common factors? Basically three things. Lot of things are, but mostly it is credibility, expectancy, and therapeutic alliance. And we talked about credibility and expectancy in the first part when we were delivering the conceptualization. uh, uh, Third component is related to therapeutic alliance. So basically, I'll talk about a little bit about the therapeutic alliance and why you are focusing to maximize this non-specific factor is that all this credibility, expectancy, and therapeutic alliance is considered as to be the significant predictor of treatment outcomes. Almost in every study, they have taken that these are the significant predictor of positive treatment outcomes. And secondly, as per expectation, it was earlier believed this credibility and expectancy is kind of is a static in it's a trait in nature, but much of studies that is coming right now, they're proving that this is not really static in nature. Rather, it can be manipulated during the expectancy. It does have a state-like properties. It may shift in between the treatment. It may improve in between the treatment. Hence, if it is so, why not to target even this component? If it is a predictor of the treatment outcome, why not to manipulate this within our therapeutic context to again have a better treatment outcome? So I'll talk a little about the therapeutic alliance. Basically, therapeutic alliance consists of working bond, agreement about the goals, and third is related to the agreement about the task. I repeat, bond, working bond, agreement about the goals of the therapy between the client and the therapist, and agreement about the task in the therapy. And why it is so much important? Say for example, therapeutic alliance, among all those things, it is this among all these non-specific factors, this is highestly studied. And secondly, the best one of the best predictors even the therapeutic alliance is the early treatment success. The more there is an early treatment success, that it predicts a better therapeutic alliance between in the therapeutic context. So what is the aim? So the aim is basically within this therapeutic to develop the therapeutic alliance, the techniques are specifying the goals. Sometimes we do specify goals of our treatment, but rarely we used to do goal monitoring. Rarely we used to do a feedback about the goal progress. And these concepts of goal monitoring, goal feedback, and specifying the goal, this is mostly used in the organizational setup by a study Locke and Latham. Very rarely, very less it has been used as compared to the organizational setup. So I'll give 1-2 minute view about this, how to specify the goals and how to monitor the goals and how to give the feedback. See,
Dr. Naren,
goals. Yes.
sorry to interrupt you,
Yeah.
because it is very nice to hear you about
Yeah,
the way
sure, sir.
you are
Fine, fine.
explaining.
So,
But actually, we are running short
okay.
of time, and we are expecting the questions from the
Oh, yes,
participants
sure.
also.
I'll end it. I'll end it. It's
Please,
better.
yes, yes,
That
okay,
I'll
okay,
end it
okay, all
better.
right.
So
Mm-hmm.
that's it. Just one line. We have to make our goals better to be functional than symptomatic. The more the goals are functional, the better is to target. Say, for example, traveling alone to distance places, going alone to crowded places, than targeting the symptom. Is need to be clear that we're not here to eradicate the thoughts, we're not eradicate the bodily sensation, rather to improve the functionals. So if you specify the functional goal, that will be more helpful. Yeah, monitoring maybe later on, any times. More important is Q&A. Please, I'm glad to answer as much as question. If I'll be happy to answer if I really can.
Yes, yes. Now, we had a wonderful session by Dr. Narendra, and we'll discuss about the feedback from my side to his presentation at the end. But I would request all the delegates or the participants from the different part of the India, please have the questions and the queries by raising your hand. And I would request the organizer also, please. Unmute them, whoever is willing to have the question to the speaker.
Dr. Manoj?
Yeah, ma'am.
Yeah, I'll just make a point and I'll go.
Yeah, yeah, sure, ma'am, sure.
Thank you for this very informative talk, Narendra. I think you have mixed both theory and practical. But the only thing is, I think you've given us so much of information, which is, overwhelming as of now. I would request you to do a workshop for all of us.
Surely, ma'am. I'll be glad. I'll be glad.
Because I think half a day workshop or a 1 day workshop, even for the participants, it's going to be very useful. Because now, if you ask me what really you did in the initial phase, I think I have to really think many times to recall. Because you've given such good information, so much of information. If you had only told us, what we could have done is we could have had it in 2 sessions.
Yeah, okay, ma'am. Yeah.
Anyway, I mean, I think we will have a workshop by you at some maybe during the conference, and I'll request Manoj to take only 2 questions because I think we are past the time. Thank you.
Yeah,
Thank you.
sure. Okay, thank you so much, ma'am. Yes, participants, please have the questions to Dr. Narendra.
You should have intervened beforehand. When I'm in flow, I'll flow. I'll just, anyways, yeah, fine.
No problem. Because I was also not willing to, interrupt you because the
Yeah,
kind
it's
of smoothness and it was mesmerizing for me too. So I was a silent listener at that time. So please, participants, because he has talked about a variety of, techniques based upon the different, models. So please have the questions and if because we are already running short of the time. I will wait for a few more
In the
minutes,
chat
2 3
box.
minutes.
There are some questions in the chat box, I think, Dr. Manoj.
Yeah, ma'am. I think that there is some problem with my system, or I'm not able to see that questions. If anybody from there can help me, it would be very great.
Dr. Suresh or Dr. Ritvik can take over if they can, because I've also logged in as a guest only.
Yeah,
even
ma'am.
ma'am, I'm not able to see the
Uh,
questions.
I am also, ma'am, as a guest.
Yeah,
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 even yeah, me as also guest also it's there, but yeah, anyways, if anyone can read out the questions, it would be highly beneficial. Yeah.
I just flashed any references they've asked. Somebody has asked for reference.
Sir, there is a question for some reference books, if there is any.
Yeah, actually that was the last part, of my slide. But anyways, I'll just, what I'll do, I'll share my, okay. Anyways, I'm just showing it. Hello.
Yeah. Participants can take a pic of this slide
Can we have a
and
screenshot of this? I'll
yeah,
highly recommend,
screenshot and pic of
these
this.
first two references are for the innovative learning concept. The third is one great chapter on specific non-specific factor, and fourth is the share of this PPT. Even I'll share it with the organizers. I don't know how they can do circulate, but even I have attached this PPT today in the evening to my SlideShare account. You can download it from there.
I'll request Dr. Suresh to put it on the website.
Yes, ma'am. He is not here because he has some health issue, and he requested that
Dr.
take
Manoj
over the things. Yeah.
or Dr. Ritvik, when he shares the slides, please put it on
Yes,
the website.
sure. It will be done, ma'am. It will be done.
Yeah.
No issue.
Thank you.
Yes. So I think the people has not only Dr. Ritvik. There was only one query about the
Yes,
book,
sir.
or
Yes, sir. There are no more
anything else?
questions in the chat box.
Uh,
If there is any participants willing to ask any question, please raise your hands. We will unmute you.
Yeah, one person has raised the hand, and kindly unmute that person. I'm not able. Two people have raised the hand.
Rajapriti, you can unmute and speak.
Thank you, sir. Hello, sir. Thank you for the session. So I would like to have a concern, like if we are working in terms of images, especially in OCD, if the
Okay.
patient is having images,
Okay.
so they have a lot of expectancy that they will get the image again and again. Even at the point of therapy, they're convinced that okay, I'm not getting the images, but constantly they have a worry that I'm going to get the images.
Okay. Okay.
So
See,
in that case, how we can do this, sir?
See, this is kind of an obsession. They will have an image. You need to ask to them question, okay, if the image will come, what will happen? What's so bad about if the images comes? Say for example, see, sometimes when we want to challenge the predominantly obsession part, sometimes people say, how to do exposure in that? My answer would be, just ask them question, what will complicate the things more? Try to understand. What is by what if means what you want to do that you think the things will be more complicated. And second questions, if the images will come, what would happen? So what if say for example, mostly the images rather easy to tackle in a sense. First I'll give a hypothetical scenario. If the images is coming, they're also having certain kind of an maybe religious or kind of something bad will happen to them. Even if that is not there, say for even it is that is not there, they will tell that I'll feel very distressed until unless that remain image is not going from my head. I'm not be able to cope. The fourth point in the ILT concept, mismatch expectancy, that is a distress tolerance. They do have a thing is that I cannot tolerate that image that is coming. Okay, you will not be able to tolerate. So what will happen? Let's see. Let's bring a image to the say for maybe download it somewhere, something like that. See it persistently. Let's see after 5 minutes you are feeling more kind of things, or you're able to tolerate as you were expecting, or you are tolerating less as you expected, or it is beyond tolerance. So this is a way you can do the exposure. Something, if there is a explicit consequences attached to that, first you need to ask them that first, then go for the distress tolerance, the second step. To again repeat, ask them if the image, yes, you are scared that images will come, so what will happen? I'll tell them if images will come, what it would mean to you, what it mean to you. Then if images is not coming, bring the image, download the image. Now the YouTube and download, Google is that, download and show to them. I'll see the image in front of me. If it is not coming, let it be in front of me only. Basically the image do have a very explicit, most of the time, explicit consequences attached. If not as target the distress level. That itself is a kind of, feared consequences. I cannot tolerate this kind of image. It is beyond my tolerance. So how much time you think you can tolerate it? Maybe 4-5 minutes. Okay, let's wait for 5 minutes. You watch 5 minutes what is happening. This is a way you can do. But first ask about explicit consequences.
Yeah, I hope that
Yes, sir.
the question is addressed properly. And there was one raised hand again. I'm
Nikhil
not able to
Kataria,
see the.
you can unmute and speak.
Thank you. Hi, sir. Thank you for that session. It was really informative.
Thank you.
Sir, I wanted to ask about exposure therapy, especially for OCD, because when we talk about one of the drawbacks of ERP is the dropout rate. Clients drop out quite faster in ERP
Yeah,
than other.
exactly.
So
Yeah,
one
do.
way to manage the dropout rate was like the literature suggests that helping the client feel in control of therapy. So if they feel in control, then it's less likely that they'll drop out.
Yeah,
Um,
exactly.
I was thinking that would variable exposure like make them feel not in control and increase
Yeah,
dropout? So I
yeah,
just want.
very frankly, it's a very good question. I'm really glad you asked it. See, first of all, the point of, exposure activities, when we'll be introducing in classical sense the exposure when the patient has accepted the conceptualization. That's why out of my 1 hour 15 minutes, I took 30 minutes for only conceptualization. So you have to, as I told now, these three things: expect credibility, expectancy, adherence. So first, the patient has to feel that this therapy is credible, and this therapy will increase my expectancy of chances of my recovery. If these two things will be there, that is a third component, adherence will come to the picture. So sometimes we have not worked with the credibility and expectancy. We are jumping to the exposure. There might be a problem. So spend sufficient time in the conceptualization stage. This is one of the example I gave you. The patient has to accept it. If the patient is not accepting your conceptualization, doing there an exposure, that will be a problematic. Even if it's not that the patient has accepted the conceptualization, there is no thing is that he will all accept the adherence. No, but likely there will be increased adherence, or into more session will come to your sessions more frequently. In that scenario, what I say that in the even I clearly clarified during my session is that when we are targeting variability, I do not do much in the variability of context we did, but variability in terms of random order, we did not do it much because we ourselves were scared what will be the scenario. And we only did when the patient was accepting it. So rather start with the initial level with very least fear. See, in 1 or 2 sessions, we mostly able to know whether the patient will be coming to me regularly or he is kind of bluffing. So it's what in a way, if the patient is, if you're not confident about his adherence level, start with the very least anxiety. In the EPD model, they start with the moderate anxiety. You start with the very least anxiety. That is the way, that is the reason I was trying to cover the non-specific factor. There I have mentioned how to start with the least anxiety and how to show him the early success. Remember, in therapeutic alliance, one of the greatest predictor of treatment outcomes is good therapeutic alliance. Yes, understood. But what is again the predictor of good therapeutic alliance? Early treatment success. Early treatment success, if it is there, there will be expectancy. Yes, you'll be more motivated. I'll do work more. I'll do work more. So hence, start with very least level of anxiety. And how even that is the reason I was trying to go with the last slide. The factor what I did is that, what we are not we did is that in our functional goals, we did not put the goals as reduction of anxiety or reduction of fear. uh, I need to show that slide. It will be 30 seconds, not much of your time. Please show that slide. I'll show to you. See, is it visible? Is it
Yes.
visible, please?
Yes.
See,
Yes.
here in the goals, what we have done, I have done like I am making efforts in traveling. I am making efforts. Say for this is not OC related example, you can just replace it. I am making efforts. I am making efforts in the OC, say for kind of thinking about those thoughts. I'm making efforts in going to washrooms. Efforts. So what we are targeting in the initial level, whether the patient is making effort or not. If there is an effort, then we'll say our early treatment success is there. So in the goals, first what we'll say that first effort has to be there in the functional areas, then we'll go to the symptomatic area. So in the initial part, you have to kind of manipulate him to show him, you have to catch them being good by showing little improvements. I words the choose the word manipulate. You have to manipulate them to show the early success in small activities. Because remember, early treatment success is the largest predictor of therapeutic alliance. And when early treatments, you'll start if there is a convincing conceptualization. Hence, let's do a convincing conceptualization. When you're afraid of this, then after that, target some kind of functional goals rather than symptomatic goals. In the functional goals, at least target first their effort only. Are you effort? Then that's good improvement. Then go to that. Yes, variable labels in terms of randomness, when you are scared, the patient is not adhering, not advisable to do. That will be done in the latter stages. Yeah, thank you. Really asked this question. So it
Thank you.
kind of give me a permission to other slides that I skipped. Yeah, kind of.
Yes. So I don't think that there are more hand raised, and we can again, as our president of CPSI told, that we can organize the conference, in the conference some kind of workshop, or any other time also we will be trying to do that. Not only OCP specific, but I would like that other disorders also and other therapeutic techniques he has been practicing in his clinical practice. We will also love to hear those things also from him. Overall, it was overwhelming to hear you after
Thank you.
a 1 decade gap, and I am hearing you, and we are the product of the same institute, and it is really very good to see you and to hear you. You have explained everything in a very layman manner. I can say is that every participant could have get the benefit of it. Like if we talk about the expectancy violations and deepened extinction, and in that the variable interval and variable ratio theory of the learning principles has been quite applied, and that's why that the impact of that was more when you are talking about the deepened extinction, right? So it was very nice overall, and I'm willing to say more, but the time is not allowing me to. And obviously, thank you so much for being here and for the wonderful session. And thank you for all the participants pan India. And even I was expecting more participation from the different part of the country, but it was less than the expectation. Anyway, it happens because we do have the continuum of learning in form of the Tuesday's learning, and we'll have that because CPSI has a aim to reach to the basically the clinical professionals as well as the trainees, so that we can update their knowledge and understanding and skills, like inviting the speaker like Dr. Narendra. And thank you so much, Dr. Narendra, once again.
Thank you.
And
Thank you.
thank you, CPSI, organizing this beautiful program. Okay, thank you so
Yes.
much.
Thank you.
Dr. Ritvik, can you end it?
Yes, ma'am, I will.
Ritvik, please
Yes,
end
ma'am.
it. Yeah.
Yeah.